You're listening to the O&P Check-in, an SPS podcast.
This podcast brings you the latest happenings in the O&P industry. We're unpacking trends and news from this tight-knit orthotics and prosthetics community.
Thank you for joining us. My name is Jackie Green. I'm a marketing specialist at SPS.
And I'm Brendan Erickson, regional sales manager here at SPS.
Welcome back to our listeners. If you're new to the O&P Check-in, here is what you can expect. In each episode, we provide a quick SPS update and discuss hot topics in O&P with leading professionals in the industry. Before we get started, let's hear a word from our sponsor. TrueLife's Matrix Pace is the perfect addition to the Matrix AFO family and the proven best sellers, Matrix and Matrix Max. The narrower footplate allows for a greater variety of compatible footwear, while the footplate is also ergonomic with a curved heel for better foot fitting. This all comes with the same grade 2-year warranty. The TrueLife Matrix Pace is now available through SPS. For more information, reach out to your SPS sales account manager or SPS customer service today. So the Core family of high-quality, low-cost items has added a new clinically equivalent bracing options. So the first option is the Core multi-POTUS boot, which is available in fleece and no fleece options. And we have those in the marketing closet right now, and they are very nice, I have to say.
Nice. So people can get samples if they want by contacting their SPS sales manager. And we've also got 2 new universal TLSOs. It's the LO464 and the LO456/LO457. These 2 new designs feature no grip fastening to empower patients with weak hand strength to apply the brace to themselves fairly easily.
Yes, and we also have those in the marketing closet, and I can say those are also very nice. Plus, in addition to those, Core items are now in our new rewards program at 7% reward discount tier when you order online. So you type Core into the search bar to browse our Core selection today, or you can just follow the links in our show notes.
All right. Joining us today is a very special guest and a friend of mine that helped me cut my teeth in the industry as a young whippersnapper. Amy Ginsburg is here to chat with us about upper extremity patient care. Amy is a certified prosthetist, orthotist, and upper limb specialist at Quorum Prosthetics based in Denver, Colorado. Welcome, Amy. So glad you could join us today.
Oh, it's great to be here. And this is my first podcast experience, so bear with me. Spend all my time in the clinic. This is, I guess, getting out to the public. But no, it's great to be here. Thanks for the invite.
Thanks for joining us.
Okay, so for our listeners out there who haven't met you yet, could you give us a little background on how you became involved in O&P? What's your story?
I graduated college from the University of St. Thomas in Minnesota, and I majored in biology and secondary education. And right out of college, I taught freshman biology in a suburb of Chicago. And the school just wasn't a good fit for me, so I left Chicago to work as an outdoor educator on Catalina Island, which is an island just off the coast of Southern California. And it was a seasonal job where we'd have to move off the island in between seasons. So I did this for about 2 years. And after that, I was ready to start my profession. And I wasn't really into going back teaching in a classroom after that because it was literally experiential education, teaching kids outside. Just teaching indoors just wasn't there for me anymore. So I knew I had to go back to school. So I wanted to do something where I could help people. And so I was looking, it was in between physical therapy or prosthetics. And my best friend growing up, her parents, one was an orthotist and one was a prosthetist. So I knew about it. I just didn't know what the day-to-day was like. So I spoke to her mom and she told me just what the job entailed. And I just knew it was the job for me. So I went back to California, volunteered, and eventually worked as a tech at a clinic in Riverside. And I knew right away that this job was perfect for me. So I decided to stay in California. I went to school at Cal State Dominguez. I graduated in 2004, and I learned how to surf and stayed there for about 13 years while working for 2 different companies before coming to Denver.
What are some of the unique challenges you have come across or that are associated with upper limb prosthesis use and individuals who are experiencing upper limb loss or limb difference?
Well, just to begin, it's important to recognize some of the feedback that I've received from patients and also some of the problems I've run into with upper extremity devices. Uh, one of which is the reliability of the device. If the prosthesis has to come in for repairs often, it's frustrating for the patient. And obviously, if it doesn't work, they can't use it. So, and also the durability of the hand is important. Getting to know what your patient is planning on doing and making sure you're providing a device that will withstand whatever it is their day-to-day is. Also, some patients require more strength out of their terminal device for certain activities. Also, how the device looks is really important. And some patients want their prosthesis to match their non-affected hand, and others want the more robotic look, but are particular to how big this terminal device or the prosthesis is. The color of the terminal device is important as well as the overall size. And, some patients want, obviously, it's important to hold an object and not have it slip out of the terminal device. So, control, precision of handling small objects. And then a lot of the terminal devices, there's the noise of the motor. And so that can be deterring to patients. And then the weight of the prosthesis, especially with, you're dealing with a multi-articulated hand with 5 motors, the distal end of the prosthesis. So, depending upon how long their residual limb is, the prosthesis can feel a lot heavier. And then, when with an upper limb deficiency, there's a huge body image component. We use our hands to communicate. It's really like an integral part of our self-identity. We use our hands for social interactions. So it's important to wrap your head around the fact that the prosthesis has to be accepted by the user. And then there's also something called prosthesis abandonment, and it's prevalent a lot more in upper extremity prostheses than lower extremity. There's a research paper that came out in 2007 that they found that about 1 out of 5 individuals who are fit with an upper limb prosthesis ultimately decided not to wear it. And so this is also a reason why I was interested in doing more upper extremity prosthetics, because I want that number to change, because I just don't think that it's my job to make sure that patients are functional with their prosthesis. So some of the reasons why rejection rates are so high, some of it is discomfort with the prosthesis, and sometimes it's just socket fit, and other times it takes so long to put the prosthesis on. Sometimes patients can't do it on their own for bilateral involvement, and sometimes patients get a prosthesis, they leave a clinic, and they never see any sort of occupational therapist for training, which you're kind of setting them up for failure, because if they don't know how to use their device in their everyday, it leads to frustration. Also, the durability factor. If a prosthesis keeps breaking for whatever reason, it's also frustrating for the patient. And then also, if your patient has high expectations and think that a prosthesis can do things that they can't, and it doesn't meet their expectations, it can also be frustrating for patients. So with prosthesis abandonment, when you're talking about a person with a unilateral limb deficiency, if they don't wear a prosthesis, they're more susceptible to an overuse injury on their sound side. And so this is a huge factor for unilateral congenital limb deficiency. as well as trauma that happens to patients at a younger age. So wearing a prosthesis helps take that load off their sound side and prolong the health of their joints of that sound side.
Wow. So you hit on a ton of good points there. And I think we could probably just stop and hit end and we'd be fine right now. But I'm going to dive a little bit deeper. Um, and why don't you back up from a 10,000 foot view? How did you become an upper limb specialist? If that's correct, and I don't know if that's a title, but traveling the States, I always find that there's these people that are kind of mythical legends, and they're like, oh, I've got this really tough patient presenting X, Y, and Z. I might need to call somebody that deals with this a lot more often in mind. Is that true of uppers? And kind of explain that.
Yeah, so the typical prosthetist may only see maybe one or two patients that have an upper limb deficiency in a year, and it might even be less. And the reason for that is majority of amputations are lower extremity secondary to diabetes. And so it's like anything else, the more you do of something, the better you are at it. And so if you don't have the exposure, it's hard to get to be proficient with this type of patient population. And so I I gravitated towards the challenging cases always. And so for me in my beginning years, it was always challenging lower extremity patients. And I had the opportunity when I left my first company and moved to my second company of being an upper extremity specialist for 7 offices. And for me, it was an opportunity to see challenging patients and test kind of keep me on my toes and help. And I like thinking outside the box. And I also just I like challenges. And that kind of opened the door to working with this patient population. And I was seeing sockets that were made and also just systems that were made that just didn't work. And to me, I'm so passionate about delivering a prosthesis that the patient can use functionally. In my experience, I've seen a lot of sockets or prostheses that the patients are unable to use the way that they should. And so I gravitated towards upper extremity, and I was looking for jobs where I can see more because unless you unless you could work for a bigger company and travel and see these patients, and I sought after jobs where I can see more and just get better just so that I can make a difference with this patient population. And so I think part of it is, you know, as a clinician, if you like doing something and you want to get better at it, it's just finding the right job that puts you in that space so that you can get better and you have the resources if you need help. But I think it's just being able to see a, a larger group of this type of presentation. That's kind of what makes you a specialist. And to me, since there's no sort of accreditation for specialties at this point, it's hard for a patient with a limb deficiency to know where to go. And I think it's our job to point them in the right direction if it's over your head, but also to seek out those people that have the experience because at the end of the day, the best patient care is for them to see someone that is experienced and is comfortable in working with this patient population. And I think the only way to do it is just to have the experience and have the background so that you can do a good job for this type of patient.
Do you think that having certifications for specializing in upper extremities would be beneficial to help the patient population maybe find a prosthetist who's a little more specialized?
I think that's where prosthetics should be headed to, is specialties, mainly because the patient doesn't know the questions to ask, number one. And, sometimes, clinicians might take on cases that they probably don't have the experience or the resources for. And in those cases, having specialties, I think, would be beneficial for both the clinicians and for the patient experience.
Well, that's cool. It's a really cool notion, and I'm just going to keep going down this line. But how many specialties do you think there would be within the profession? And I guess for you, can you quantify how many upper extremity specialists that are out there right now, so that people can kind of realize who to look for?
Yeah, I think with bigger companies, I think they delegate who are the ones that are going to travel to see these patients because they have the bandwidth. And there are specialty upper extremity clinics in the country as well. I think in the community that you're in, I think it's important to know what's around you if you don't have the bandwidth and if you don't have the resources, and to know who to reach out to. But I think at this point it varies by whatever region you're at, and also in rural towns they're having to travel to bigger cities to find clinicians that are able to do the job for a lot of these traumatic injuries. I'm not sure if there's any sort of database to show upper extremity specialists, but I mean, at this point, I think it might even be reaching out to an upper extremity uh, company and seeing who they suggest a specialist closest to wherever the patient is.
Gotcha. So kind of organic right now, word of mouth, reach out, ask good questions, find the solutions.
Yes.
So, I mean, you went into a lot of things, and one being adoption of the prosthesis. How can clinicians better support their patients and really promote them to use it and like it and feel good with it? Without giving away your tricks? What can people do?
I think it's important for the patient to be part of what I call an interdisciplinary team. So that includes the patient's family, for the physician that might have referred the patient to the prosthetist, but also I've had conversations with surgeons prior to amputation just to make sure that they're doing the best for the patient in the amputation while thinking about the prosthetic that they're going to adopt. So the prosthetist would be part of this group, occupational therapists, and maybe psychologists or case managers if the patient has those. And so communication is really important. Communication with the patient, find out what their goals are, have the patient be part of the process. You educate the patient on all the different types of upper limb prostheses and how they work, and also explaining the benefits and the drawbacks of each type of prosthesis, so that you can set expectations right away and the patient could be part of this process. Also finding out what their work duties are, if they're planning on going back to work, maybe some hobbies that they'd like to get back to doing, just kind of their everyday. Do they cook? Are they cleaning in the house? They take care of kids. Also, looking at their presentation, the length of the residual limb, myotesting them, see if they have oppositional muscles that fire independently to see if they can operate an externally powered device. And these all factor into the design and the components that I would put together so that I can provide the most functional prosthesis for the patient. And it's also important to know that there's not one device that will fulfill all of the functions of a human hand. And this is the challenge. So having open communication with the rest of the interdisciplinary team throughout the process just sets the patient up for success. And as a prosthetist, knowing that upper extremity takes more time than lower extremity is really important. Also, early intervention. So Fitting patients right away with a prosthesis helps prevent prosthesis abandonment. And it used to be that this window was 30 days, but I've read in other places that 12 weeks was a good period to be fit with a prosthesis after their initial amputation. And then diagnostic fittings are really important. It's a way that I can assess the motivation of my patient. I can see their determination and also their gadget tolerance. But also, it's a way for the patient to assess the function and also the limitations of the device. And at that point, I can educate them about possible componentry options. And I can also address problems or issues they're having in this stage before it goes to a definitive. And there have been times where I have to just start over because the design just doesn't work for the patient. And you have to be okay with that. And also, I have plates, forks, knives, clay to simulate food because I think it's important to show the patients how to eat with two hands with their prosthesis and their sound side. They can practice picking up different objects, tying their shoes. The idea is to set them up for success right away. Show them how to use a prosthesis, have them take it home so they can use it at home before it's finished.
So, do patients have a preference, or have you noticed that there's a preference between body powered or electric upper limb devices? Or is it really just a patient by patient, case by cases sort of decision?
Yeah, I don't think anyone's ever come into my office requesting a body powered device. It's, the influence of the media is heavily into the externally powered devices, the multi-articulated hands, the robotic, electric prostheses. But my job is to educate my patients because there are benefits and drawbacks to both. But also, if you wait for the limit to mature for an externally powered prosthesis, you're prolonging the initial fit. And so fitting a new patient with a body powered, it not only gets them to use a prosthesis faster, but if and when they get an externally powered device, they have a backup if there's some sort of failure in that externally powered device or if it needs to be repaired.
Yeah, and I would say that there's been a ton of advancements. You mentioned the media, and I feel like with 3D printing, especially because it's not a weight-bearing device, people are making these as their, college project to end school. They're forming a design and printing it, and who knows where it's all going to go. But you as an expert, what do you think are the advancements in upper limb technology that have really, I guess, pushed it for the betterment for patient experience?
I would have to start with the control strategies for externally powered devices. Originally it was just dual site using two oppositional muscles to operate the whole prosthesis. And now there are multiple companies who have come out with their own pattern recognition systems. And then if you couple this control strategy with a surgical procedure called targeted muscle reinnervation, the user has so much more control over the device. And I'll back up. So for those of you that aren't familiar, so pattern recognition allows the patient to create their own patterns to make an arm or a hand movement, which is more intuitive for the patient than using the same two oppositional muscles to cycle through all of the components of the prosthesis. But with pattern recognition, there's an array of multiple electrodes to create all these patterns, and they work together. And then targeted muscle reinnervation is a procedure originally performed to remove or prevent neuromas by providing the nerve endings with a new muscle to innervate. And so this helps to provide even more signals for the patient to create more patterns and have better control over the prosthesis. I'm currently working with a younger, very technologically savvy transradial patient who had targeted muscle reinnervation surgery. And I recently tested him just with a demo coapt cuff. So coapt has just a cuff you can put around the residuum, and see how he works the system. So I just had him, I typically just start with open and close, just making sure that they can be successful. And he just wanted to shoot for the moon. He said, program 4 grips. Let me see what I can do. So we calibrated the system. He was able to cycle through open, close, and all of the 4 grips without fail, first time, which is better than even I did when I put the cuff on me. And so he can feel all of his phantom fingers, which helps to create these patterns for different grips on a multi-articulated hand. And he can just have direct control into every grip that he wants to go into. And so surgical techniques, another surgical procedure is osseointegration. So we're now able to fit very high levels of upper limb amputation and give the patient so much more function because you're not having to deal with a socket and you have more range of motion, both like externally powered and body powered. It provides so much more function for the patient. And then additive manufacturing. I know Brendan, he started talking about it. So now we can create lighter devices. We can customize the design, and it just allows more freedom than traditional lamination. And so I'm privileged to work for a company called Quorum, and we have our own engineers on staff as well as our own multi-jet fusion printer. So pretty much the sky's the limit when it comes to upper extremity prosthesis design. And I'm just looking forward to just perfecting design, fit, and function because I have everything now at my fingertips.
So, Amy, I remember when you talk about dual site, it's just basically flexion and extension of your wrist, right? For say
if it's a transradial, correct.
Right, if it's transradial. And then, so are you saying now with the multi-point, it's almost like you could rotate your wrist in like a circle and there's all those different points being read on the muscle bellies, or how does that work?
Instead of in dual site, you have to address the wrist before you can address the hand. And then to change grips, typically you have to cycle through the grips to get to the grip that you want to. Every terminal device is different, but just to keep it simple, dual site, you have to cycle from proximal to distal if there's an elbow joint, if there's a wrist joint, and then if there's a TD. So you have to start, it's called sequential control. But with pattern recognition, you can go directly to each joint. You can go directly into each grip because you can create a pattern to associate with supination, with pronation, directly to grip. So you're not having to like co-contract to switch from wrist to hand, or there are signals that you have to throw to with dual site to change control from component to component, proximal to distal. So with pattern recognition, you can go directly into whatever motion you want without having to cycle through, if that makes sense.
So for listeners who are interested in trying to learn more about fitting uppers or have a particularly tough patient presentation, what resources would you recommend? I know you kind of talked about like reaching out and trying to find someone who specializes, but if you have any other tips or tricks or places that you recommend looking.
Yeah, sure. So, I mean, I'm fortunate to have worked with some really talented prosthetists that I'm able to reach out to. And I think it's kind of networking through this field. I mean, Brendan, I've known you for a really long time. And with each person that you meet, everybody brings something different to the table. So just kind of keeping your network and not being afraid to reach out. I've also worked with some amazing occupational therapists, and I learned so much from them that I can bring to my patients. I'm also kind of a nerd when it comes to socket design and social media. You can see what other clinicians are doing. I actually learned from that and like to contribute as well with, cool socket designs for uppers, just to kind of, bring it to the surface and allow people to see, just to kind of propel just the technology of what's happening. Also, I would have to say trial and success. It can be painful sometimes, but learning from what doesn't work and being able to find new ways to solve problems is how you get better as a clinician. The Academy has an upper limb society, which is a group of clinicians that have a ton of experience, and that you can be part of if you're part of the academy. They also have courses online if you're interested in that. I also learned from other patients who have been living with upper limb involvement for a long time. Especially I have bilaterals that I lean on to learn how they get through their day to day. Usually, I'll use them for a new patient with the same presentation because they've figured out ways of doing things that are good for them, which might work for other people. Skills for Life. It's a bilateral upper limb loss workshop, and it happens every 3 years in Houston. And it's for those that have bilateral upper limb deficiency at any level, and it's for caregivers, family, prosthetists that work with this patient population, occupational therapists, and what's really special. I was able to go October. It was 2022. It's like if you have two hands, you are a minority, which is insane. It's insane for the people that have bilateral upper limb deficiency, because it's like the first time in their life that they see people that are like themselves, and it gives them a chance to socialize. There's recreational and social events, tips and tricks, techniques for just day-to-day living. There's breakout sessions for males and females so that they can be comfortable to ask the questions specific to female problems versus male problems. There's informational sessions for caregivers, prosthetists, OTs, and it's it's a it's a place where you just meet others and you just learn off of each other. I learned a ton from being there. In the last Skills for Life in 2022, there was 73 individuals with bilateral upper extremity limb involvement, which is crazy. I mean, it was probably the best event I've ever been to.
Wow, that's awesome. I mean, those are tons of resources. What about on the additive device side? If they have questions about some, well, shoot, I guess we don't even need to limit it to upper limbs, but can people rely on Quorum and you guys as um, a service provider for additive printing?
Yeah, so Quorum's been fine tuning their lower limb sockets for a while. So transfemoral, transtibial, it's dialed in. I started working at Quorum just a month ago, so I'm just getting my little feet wet, and you know, come back to me in a year, and I will probably have an answer for you. I still make a diagnostic instead of laminating it. It's just a matter of figuring out ways to build it through additive before I print it. So the socket is the same. It's just figuring out if I'm going to make it adjustable, or if there are little tricks I can do for just building the design just to take the weight off. So I think what's exciting to me is it's kind of a whole nother tool in my toolbox that I can use. And I think there's a huge benefit for partial hand as well as any sort of transradial, transhumeral prosthesis. So I'm excited to see where I can go with this, because I think additive manufacturing is exactly what upper limb prosthesis needs. I think it's gonna change the game a little bit.
So, Amy, this has been wonderful. We kind of put together these questions. Is there anything that we're missing that we don't know about that you want to expand upon? Anything else you want to add?
Yeah, I think it's important to understand the commitment you have to have when dealing with patients with upper limb deficiencies. but also understanding and knowing that there are many challenges, including coding changes that have recently happened, which affect reimbursement, and knowing the time that's needed to go into these cases, and also the resources that you have to have for this patient population. And I I believe we need more dedicated clinicians to take an interest in the upper extremity population, but also be willing to take the time necessary to provide the care that they deserve.
Yeah, that's awesome. Thank you so much, Amy.
Yeah, seriously, thank you for joining us today. This was fantastic.
Thank you for having me.
So, if you would like to learn more about Amy's work at Quorum Prosthetics, visit quorumprosthetics.com, and that is QUORUM prosthetics.com, or follow the links in our show notes.
Well, there you have it. Thank you for listening to the O&P Check-in, an SPS podcast.
If you like what you hear, hit the subscribe button on Spotify, Apple Podcasts, Stitcher, or wherever you listen to podcasts. Please rate and review the show to help fellow O&P professionals find us.
We'd also like to hear from you directly. What topics do you want us to cover? Do you have any burning questions? Email us with your thoughts and feedback at spspodcast@spsco.com. See you next time.
Bye!
Bye.